risk of air trapping, that is also taken as true, right? Okay. Next question. Okay. Which clinical manifestations are correctly matched with the disease, right? Neurofibromatosis type 1 and retinal hematomas, right? So, retinal hematomas are, they are a characteristic feature of tuberous sclerosis, right? It's not NF type 1, right? In neurofibromatosis type 1, there are certain other features like cafe au lait spots that you know of, and there can be neurofibromas, like, and also there can be leash nodules in the eyes, right? And also there can be gliomas, right? Retinal hematomas you commonly see in tuberous sclerosis, so therefore this is false, right? Galactosemia or erythroid cataracts, that is also true, right? Because when there's accumulation of galactose, as I mentioned, it can deposit in various organs, right? It can deposit in the eyes, leading to cataracts as well, right? That is true. Wilson's disease, KF ring, that is that all you know, due to copper deposition in the cornea, it can give rise to KF rings, right? And what are the investigations that you do to confirm the diagnosis of Wilson disease? You go for urinary copper excretion and also cerebral plasmin levels, right? That is true. The rheumatic fever, erythema multiforme, right? Uh, what occurs in rheumatic fever is erythema marginatum, right? Not multiforme, right? Multiforme is a sort of hypersensitive reaction, right? It's an immune reaction, type 4 immune reaction, which can be seen in conditions like uh, herpes simplex virus, right? And mycoplasma, like in those conditions, you see erythema multiforme, right? But in rheumatic fever, what you see is erythema marginatum, right? Not multiforme, right? So that is false. Then the last one, tuberculosis, scrofulodoma, right? Scrofulodoma is it's a sort of cutaneous condition, right? Cutaneous manifestation of TB, which can commonly be seen near to the lymph nodes, TB lymph nodes, right? That is a cutaneous TB condition, right? Therefore, it is true, right? So, about the skin manifestations of TB, you should know of skin manifestations of TB. You can categorize it into two parts, right? One is direct tissue involvement. Direct tissue involvement. Other part is due to immune reaction, right? TB related immune reaction, right? There are certain conditions which occurs due to direct tissue involvement, right? Right, scleroderma, and certain other conditions like lupus vulgaris, like erythema nodosum, lupus vulgaris, erythema nodosum, right? Those conditions occur due to direct tissue involvement by TB bacteria, right? And there can be certain other skin conditions which occur due to immune reactions, right? There's sort of conjunctivitis, right? Conjunctivitis is the commonest one, which occurs due to immune reactions due to TB, right? That you should keep in mind, right? Now, the next question. Okay, let's move on then. The first question is, a one-year-old suddenly develops cough and cyanosis while eating a grape. He's conscious but unable to cough effectively. What is the most appropriate immediate next step, right? Yeah, this is foreign body aspiration, foreign body inhalation. This is also a commonly asked question, right? You should know the uh, this flow chart, how to manage a child with foreign body aspiration, right? First, you have to check whether the child is able to cough effectively, right? If the child is able to cough effectively, you should always encourage the child to cough, right? But if the child is unable to cough effectively, it means that the airways is severely obstructed, right? Airways severely obstructed. Uh, in that instance, we have to go for other maneuvers, right? Now, if it's a infant, right, child less than 1 year, what we do is back blows. You can see back blows and chest thrusts, right? Chest thrusts to uh, uh, put the foreign body out, right? But in a older child, what we do is what we call Heimlich maneuver or is abdominal thrusts, right? You can see in the picture, right? We don't do the perform the abdominal thrusts in an infant because it can lead to splenic and liver injury, right? The question they're asking about this is a 1 year old child, 1 year old child develops cough and cyanosis while eating a grape, right? Is conscious but unable to cough, right? Unable to cough. Is unable to cough, right? Therefore, we have to do one of those maneuvers, right? So since this is a 1 year old child, we can't go for abdominal thrust. Therefore, the answer is back blows, right? Back blows followed by chest thrust, right? It's always easier when you go with this flow chart. Right? Okay. The second question. 10-year-old child admitted with severe asthma on aminophylline infusion. A few hours later, his heart rate is 280 and blood pressure is 80 by 50 and is also having low volume pulse with increased CRFT, right? What is the best management option for this child, right? Now, the important points given is in this question now, this is a 10-year-old child, severe asthma on aminophylline infusion with high heart rate, right? So he's having tachycardia, it's slightly low blood pressures, the low volume pulse, increased CRFT, right? Now he's having tachycardia with low volume pulse, right? So he's tachycardic and he's hemodynamically unstable. Hemodynamically unstable, right? Or we can assume that the child is having a certain form of arrhythmia, right? Why? Because this aminophylline, as a side effect of aminophylline, it can cause arrhythmias, right? Arrhythmias, especially SVTs, supraventricular tachycardias, right? SVTs are common with arrhythmia, aminophylline, right? So therefore, we can suspect that this child is having SVT along with hemodynamic instability. Sorry, hemodynamic instability, right? So, what is the management? In a child with SVT and hemodynamically unstable, we should always go for immediate cardioversion, right? Immediate DC cardioversion is the answer, right? If the child is hemodynamically stable, we can consider vagal maneuvers, right? Vagal maneuvers, and also can consider IV adenosine. But here, since the child is a severe asthmatic, we can't give adenosine, it's a contraindication, right? If child was hemodynamically stable, we could have considered vagal maneuvers as well in this instance, right? Okay. And additional point, uh, you should know how we give IV adenosine in the ward. Uh, it is a it's given as a bolus, right? It's given as a bolus with a push bolus, right? Because IV adenosine has a very small half life, very short half life of around 10 seconds, right? 10 seconds, right? So therefore, it's administered with a bolus of saline, right? Through a peripheral vein, right? That is how we give adenosine, and we can repeat the boluses as well. We start with the dose of around 6 milligrams, right? 6 milligrams and repeat, right? Repeat for a maximum dose of 12 milligrams, right? That's how we give adenosine in the wards, right? The toxins, they can remain in heated food as well, which can give us these immediate symptoms like after 2 hours, right? The last question. 2-year-old child presents with uh, bowing of legs and delayed walking. Labs show normal calcium, low phosphate, high ALP, elevated PTH, 25 OH vitamin D low. What is the most likely diagnosis? What is the most likely diagnosis? X-linked hypophosphatemic rickets, nutritional rickets, vitamin D dependent rickets, chronic kidney disease, mineral bone disorder, hyperparathyroidism. Right? Now, with these symptoms, with bowing of legs, delayed walking, we can assume that the child is having rickets, right? Child is having rickets. But out of these three, what type of rickets is a child having? What type of rickets child is having, right? Now, first, we should understand how vitamin D activation occurs in the body, right? Vitamin D activation occurs in the body. Vitamin D we get from the sunlight as well as from diet, right? Initially, what happens is in the liver, it gives rise to 25 hydroxylation, 25 hydroxylation in the liver, right? Which produces 25 hydroxy vitamin D. Vitamin D, 25 hydroxy vitamin D is produced, right? Then it goes back to liver, sorry, kidney, goes back to kidney, where 1 alpha hydroxylation occurs and produces 125 dihydroxy vitamin D. 125 dihydroxy vitamin D, right? This is the uh, this is the active form. This is the active form of vitamin D, right? Which we also call calcitriol, right? Which is the active form of vitamin D. Right now, let's take these three types of rickets one by one, right? Nutritional rickets. Nutritional rickets. There what happens is there the vitamin D in diet is low, right? Or there's reduced sunlight exposure, right? So therefore, uh, reduced vitamin D, and the serum calcium levels, they can be slightly low or normal, right? Slightly low or normal. And phosphate is low. Why? Uh, why? Because vitamin D increases phosphate absorption from the gut, right? So due to vitamin D deficiency, there's reduced phosphate, right? Right. And that's increased PTH, right? Increased PTH, right? Because as due to vitamin D deficiency, the negative feedback effect, there's increased PTH secretion from the parathyroids, right? Leading to hyperparathyroidism, right? And ALP levels are also low because increased parathyroidome activates osteoblast, leading to increased ALP levels, right? So these are the findings we get in nutrition records. Now, vitamin D dependent rickets, vitamin D dependent rickets, there are two forms, right? One is uh, there's uh, dependent rickets. So in one form, there's deficiency of this enzyme, right? This enzyme in the kidney, right? 1 alpha hydroxylase enzyme deficiency is there. 1 alpha hydroxylase enzyme deficiency is there, right? So this formation does not take place, right? 25 OST to 125 OST does not take place, right? So what are the metabolic abnormalities? Calcium levels are low due to low vitamin D levels. Phosphate is low. High PTH, high PTH, and uh, and uh, and what happens is uh, this 125 hydroxy vitamin D levels are decreased, right? Because this enzyme is not there, so these levels are which is decreased, right? That is in vitamin D dependent rickets type 1. Now there's another one called vitamin D dependent rickets type 2. There, what happens is there's resistance in the body to this active form of vitamin D. There's resistance in the body to active form of vitamin D. There are also in the as in previous terms, there's reduced serum calcium, reduced serum phosphate, and increased PTH. And here, the 125 dihydroxy vitamin D level is increased because the resistance, the levels are increased, right? Here, 125 one is increased, right? There is difference between type 1 and type 2 of vitamin D dependent rickets, right? Now, the other form of rickets is what we call X-linked hyperphosphatemia rickets. X-linked hyperphosphatemia rickets. So there what happens is there's increased renal wasting of phosphate. Increased renal wasting of phosphate. Increased renal wasting of phosphate. Therefore, reduced serum phosphate levels and reduced serum phosphate levels, right? And here the calcium is normal, right? Calcium levels are normal. Only the phosphate is affected, right? And PTH is also normal because the calcium levels are normal, right? So here the main abnormality is reduced serum phosphate levels, right? Okay, now here The calcium level is normal. Okay? The calcium level is normal. Phosphate is low, right? And the LP level is very high. PTH is elevated. 25 hours vitamin D is very low. What is 25 hours vitamin D? It is this form, this one. This one is very low, right? So what does it indicate? Can it be X-linked hypophosphatemia rickets? In X-linked hypophosphatemia rickets, what happens is uh, the PTH levels usually normal, as I mentioned, right? So PTH elevation is not common, right? So therefore, it can't be this one. Nutritional rickets, yes, it can be true because calcium, no, calcium is low. Vitamin D level is very low. Yes, calcium is low, phosphate is low, PTH is high, and LP is high. Right? So therefore, it can be a nutrition rickets. Vitamin D dependent rickets. Vitamin D dependent rickets, what happens is there can be reduced, as I mentioned, 125 dihydroxyvitamin D in type 1 and increased 125 dihydroxyvitamin D in type 2, right? So it is unlikely to be vitamin D dependent rickets as well, right? So based on these findings, uh, the diagnosis should be nutritional rickets, right? Nutritional rickets with diagnosis. It's a bit complex understanding about these types of rickets, but just get a general idea about the basic metabolic abnormalities that you're gonna get in rickets, right? Okay. So with that, we finished the component, right? So if you have any questions regarding any, if there's associated tuberous sclerosis, we usually go for vigabatrin, right? Vigabatrin. But here, there's no tuberous sclerosis. Therefore, the first line should be to go for ACTH, right? ACTH. That is the answer for this question, right? Uh, Next one, 28-week preterm neonate weighing 1 kilogram develops exhaled temperature of 32.5, bradycardia, and lethargy. Right? Which of the following is the most appropriate immediate action? Right? The last paper also, there were certain questions from hypothermia, right? So it's better if you study this properly. So hypothermia means the temperature usually below 36.5. So neonatal hypothermia is a very severe condition because they can develop complications like respiratory depression, hypoglycemia. So likewise, many complications can arise due to this hypothermia itself, right? So therefore, it should be managed immediately. Now here, uh, along with this hypothermia, the child is having other symptoms like bradycardia and lethargy as well. So therefore, the management should be to immediately rewarm the child. Immediate thermoregulation is required, right? So let's go to the answers. Place under a radiant warmer and consider incubator care. Yes, that is the uh, best method, right? Best method to for thermoregulation, right? So we rewarm gradually, and we can protect the child from against the heat loss. Right? That is the best management step. Begin slow rewarming via cold gel packs. No, because the child has bradycardia, lethargy, and is slightly unstable as well. So therefore, immediate rewarming is required. Slow rewarming via cold gel packs won't help, right? So it's no. Delay feeding until temperature normalizes is nonsense. Administer fluidotics to reduce fluid download. No. Observe and monitor also. Now we have to act immediately. Right? So therefore, the best management would be to place under radiant warmer and consider incubator care. Right? Now here, I would like to tell you about certain pathophysiological features of hypothermia in neonates because it was asked in the previous question papers as well. Now, why do neonates tend to get hypothermia? There are certain features of neonates which uh, help that. They have a higher ratio of body surface area to body volume, right? Higher ratio of body surface area to body volume. That's high body surface area, right? Therefore, there's risk of heat loss and hypothermia, right? And also the head is accounting for a large surface area, which also accounts for heat loss. And their musculature is small and they can't shiver like us, right? And also the insulation is poor and they can't move into a home area like us, right? Slow neural response like these conditions, they are more prone to get neonates are more prone to get hypothermia, right? So these pathophysiological conditions were asked in the previous exam papers as well. Next question. A 5-year-old boy presents with intermittent pallor